indications of abdominoperineal resection, preoperative preparation we follow in our setup, and operative steps and complications associated with abdominoperineal resection. Abdominoperineal resection is also known as a Miles procedure.
We can skip this. We'll save some time by going to the procedure straight. This is not required.
Yes. Yeah. An indication is low-lying rectal cancers involving the external anal sphincter and the levators, carcinoma anal canal with failed neoadjuvant chemoradiotherapy, and melanoma of the anal canal, and sarcomas of the pelvic floor muscles.
1 second. In carcinoma of the anal canal, you have written failed neoadjuvant therapy. Is that right?
Sir, the anal canal cancer not responding to the neoadjuvant chemoradiotherapy.
No. What do you mean by neoadjuvant chemoradiotherapy? Please get your terms clear. What is a neoadjuvant chemoradiotherapy?
Sir, neoadjuvant chemoradiotherapy.
Since you obviously don't seem to know it, let me clarify it for you and for all the panelists who are hearing. Neoadjuvant chemoradiotherapy means that you are giving it prior to doing surgery. Okay?
Yes, sir. Yes, sir.
Yes. In a carcinoma of the anal canal, you do not give neoadjuvant chemoradiotherapy. You give definitive chemoradiotherapy. You are trying to heal it's a squamous cell carcinoma of the anal canal, not an adenocarcinoma, let us assume. You are trying to treat it with chemoradiotherapy so that you don't require any surgery. So you don't call that neoadjuvant chemoradiotherapy. You call that as definitive chemoradiotherapy. Please understand the terms. This is wrong to use the term because according to your line, it means that every patient of carcinoma anal canal has to have an APR because you give neoadjuvant RT-CTR, which is not true. If the tumor completely goes as a squamous cell carcinoma, 80% of the patients will not need a surgery. So that's the point, that you have to give definitive chemoradiotherapy, not neoadjuvant chemoradiotherapy. Sorry, that's the difference because the amount of radiation you give, the amount of chemotherapy you give is more in definitive, and it's a different regime compared to neoadjuvant. If it's an adenocarcinoma of the anal canal, then yes, if you have given neoadjuvant and it fails, then you can go ahead for surgery. But there also I will give definitive chemoradiotherapy because my aim is to give more radiation chemotherapy and hope that the tumor completely disappears. So I would be doing that rather than giving neoadjuvant chemotherapy because I do not plan to operate upon anal canal unless there's a residual disease. So you can't use the word neoadjuvant. It's definitive chemoradiotherapy.
Yes, sir. So next slide, Roulier classification was published for the low rectal carcinoma in 2013, and they have divided the low rectal carcinoma in the supraanal, juxtaanal, intraanal, and the transanal. In type 4 transanal classification, because of the involvement of the internal and the external sphincter, abdominoperineal resection is required in this type of the rectal cancer.
No, there is an arrow pointing to something. What is that arrow pointing? What is that?
Sir, this arrow is the resection line. This is dotted line is showing the resection line. In type 1, the resection line is resection line is
resection line in the last in type 4 showing.
Type 4 is at the levator. It's the abdominoperineal resection margin at the levator. We have to transact.
So this is an extra levator.
Yes, extra levator
resection. Okay,
yes.
This is not the normal abdominoperineal resection. Okay.
Okay, sir.
Extra levator abdominoperineal resection. Okay, so you go much more lateral on the levator ani. Then normally you divide the levator ani, but it's much closer. It's where it is in the third diagram where it is slinging the thing. Okay, right. Okay, so you should know those points very clearly. Yeah.
Yes, sir. And principle in the abdominoperineal resection is the complete tumor resection with the negative circumferential margin, and complete resection of the rectum and the mesorectum as a single unit, and total mesorectal excision with autonomic nerve preservation is the goal during the abdominoperineal resection.
What autonomic nerves are you talking about?
Sir, autonomic nerve preservation in form of a superior hypogastric plexus, hypogastric nerves, and pelvic sympathetic, parasympathetic plexus, and the inferior hypogastric plexus.
So tell me, what are the nerves that you're trying to preserve? To what organs do they go?
Sir, superior hypogastric plexus carries the sympathetic fibers from the L1 to L3.
Nerves go to which organs which you are trying to preserve?
Sir, pelvic organs, prostate, seminal vesicles, and the urinary bladders.
Who bothers about the prostate nerves, man? Who bothers about the seminal vesicle nerves? You bother about bladder.
And urinary bladder, yes.
What else?
And sir, in female reproductive organs.
Look at the female. What about in the male? What else is important? What is the most important thing that you want to protect? And which you can't always protect, which you must discuss before the operation.
So the bladder neck area to prevent the retrograde.
Bladder. Something else apart from bladder. You're not thinking ahead of bladder. See, you're not talking of ejaculatory function.
Yes, sir.
So you have to talk of erection problems and ejaculatory function, especially erection problems. Ejaculatory function is more a sympathetic drive from L1, L2, but you may maximum have retrograde division, but you won't have erectile function if the nervi erigentes. You should use that word, the nervi erigentes.
It's a pelvic sympathetic nerve, parasympathetic nerve from the S2, S3, and S4.
Where do the nervi erigentes come during your resection of the rectum?
Sir, during the lateral dissection?
No, they do not come during the lateral dissection. If you stay on the lateral dissection away from the pelvic wall, the nerves actually leave and go anteriorly. So if you look at a diagram, and you please look at my hands.
Yes, sir.
This is a median stalk. It comes, the nerves then turn up and go anteriorly. So it is not near the lateral ligament that they are injured, unless you go very laterally and you do a lot of this thing. If you stay closer to the rectum, the nerves have already gone anteriorly. They've gone anteriorly. See, this is a common mistake that people make, that they think that they injure it during the lateral dissection. It is not so. In the lateral stalks, the nerves don't come close. They come in the lateral stalks and immediately go anteriorly. Whereas in the lateral stalks, what comes more is to the nerves, to the sphincter. And so you may have some continence problems, but the nervi erigentes go anteriorly because they have to go anteriorly, and they go anteriorly where?
Sir,
in dissection yesterday, you should know this. Where do they go anteriorly?
Yes, anteriorly, it lies anterior to the denonvillar fascia to supply the urinary bladder and the seminal vesicles. It's
not the urinary bladder, it's the ejectile function. It is not the bladder. The bladder nerves come from behind. You know, the reverse V, the two nerves that go from the hypogastric plexus, they supply the bladder, and injure them, the patient will have bladder dysfunction. Anteriorly, you have erectile dysfunction. And the nerve erigentes actually travel in the plane between the anterior layer of the mesorectal fascia, denonvillous fascia, and the posterior layer of the denonvillous fascia. So there are two layers, and they travel in between. Now, if you stay posterior to the posterior layer, you will not injure the nervi erigentes. But then if the tumor is anteriorly placed, you won't get tumor clearance. Therefore, if you have an anteriorly placed low tumor where you have to clear the fascia such that you don't have local recurrence, you have to discuss with the patient pre-operative.
Yes,
whether he is willing to accept an erectile dysfunction. It doesn't matter whether he's 50 years or 60 years old. Some patients may not accept it. So you have to talk to them frankly, and you have to get consent for them, because otherwise they'll come and sue you saying you never told me about it. So this is a very important part of the operation that you must tell patients about.
Yes, sir.
And if the patient is very particular, then you should ideally have a pre-operative erectile function objective test by the urologist to make sure that they are already having erectile function. Suppose they didn't have erectile function before, then you will not be blamed after the surgery. So these are the important points in an anteriorly placed tumor in a rectal resection, which is very important. And don't underestimate the importance. If it's an anterior placed tumor, to get a facial clearance, you have to go anterior to the anterior layer of the denonvillous fascia. So because that area is very small. So you have to get clearance. The denonvillous fascia has to come with the rectum, in which case the nervi erigentes are very likely to be injured. So in an anterior tumor, you may have to discuss the chances, and that you may have to injure, because the primary aim is to save life. But if the patient doesn't want a life but wants quality of life, then you may have to change your line of management and in which case you have to tell the patient beforehand that your chance of an anterior resection is very high, recurrence is very high, and therefore you are not interested in saving it. You have to be very clear in this discussion. So please know the nerves. The bladder nerves come from behind. The nervae erigentus that look for erection, they come from front. Don't confuse the two. They are two different nerves. And the two nervae erigentus lie between the anterior and posterior layers of the tenon-villus fascia, which is anterior. Okay?
Yes.
Go ahead.
Preoperative preparation in form of stoma marking and counseling is required because it is the end stoma. Mechanical bowel preparation with the oral antibiotics
It is not just an end stoma. What else is it?
And permanent stoma.
Yes. So you have to tell that patient clearly that. So I get every year at least 3 or 4 patients who come to me after an abdominopenic resection and tell me, please reverse this resection, and I want to go for naturalis. So I tell them that it is not possible. They say, no, the doctor told me that after 2 years it can be reversed. I said, then you go to the doctor who told you that it can be reversed and ask him to reverse. He said he doesn't have the skills, that therefore he has asked me to see you. I said, sorry, even the best surgeon in the world in MD Anderson or Memorial Sloan Kettering cannot reverse an anterior and abdominopenic resections. That's it. Period. This cannot be reversed. Why this has happened? Because the patient has not been told it's a permanent stoma. So that is unethical in my opinion. So don't talk to the relatives, talk to the patient. Many relatives will say, sir, don't tell him. You do it, we will tell him later. Don't agree to that. I tell them, no. This is something I need to tell the patient myself, and I need to tell him it's permanent. Now, I don't care if he doesn't get operated by me. You must be willing to have the patient walk out on you and go to some other surgeon. Yeah, that's okay. I don't mind. I will not lie to the patient. Okay, other surgeon may operate on him, and I've had patients who walked out on me, gone somewhere else and got an abdominoperineal done, and then they said that they've said they will put it below, but they couldn't, and that they can do it at a later stage, so I've come back to you. I said it cannot be done. You can go and ask them whether they can put it back, and if they can say they can put it back, let them try. So be very careful. Don't try to think. Okay, then next.
Sir, mechanical bowel preparation in our institute, we follow with the giving the Paglac 1 sachet in a 1 liter of the water at the during the evening times, and oral antibiotic in forms of the oral metronidazole tablet 400 milligrams single tablet, and DVT prophylaxis, low molecular weight heparin, single.
Is that a recommended line of management for oral?
It's not recommended, but for a better handling of the left-sided colon, we usually prefer to give.
What drug is actually recommended for oral antibiotics?
Sir, neomycin 1 gram and oral metronidazole.
Recommended is actually erythromycin with neomycin.
Yes,
sir. Is the recommended drug, isn't it? It is not it is not. Metronidazole is no longer, is not recommended. It is generally neomycin or vancomycin orally, along with erythromycin orally. Okay, both neomycin and vancomycin have no absorption from the gut, so they will not get absorbed, so they won't cause any other toxicity. And now vancomycin is coming as a tablet in some companies, if you can get it, which you can give for this bowel preparation along with the erythromycin. The best drug would be erythromycin estolate, which is not available here. We have to use erythromycin stearate here, which is available, but we can use that as 250 milligrams every 8 hours now.
And so DVT prophylaxis, we give low molecular weight heparin 0.4 milligrams subcutaneously 12 hours before the surgery, and preoperative antibiotics according to institute choice, and preoperative counseling regarding this.
Though this is recommended, I do not use DVT prophylaxis preoperative. I use it 6 to 8 hours after surgery. I started, though it is recommended, because our anesthetists are not happy with giving any low molecular weight heparin preoperatively. Now, you may argue that it may not cause bleeding, but the argument that I like to ask is that if it is not going to cause some platelet dysfunction, if it is not going to cause some clotting abnormality, then it is not working. So it has to work means it is causing some abnormality. It is prolonging something from clotting. So whether if you say it's a prophylactic dose, see, if it means that it's ineffective, then you can give it. But if it's going to be effective, that means it is going to cause some prolongation of bleeding parameters. So I don't like to give anything pre-operatively. I give it always post-operatively. 6 to 8 hours post-operatively, we start routinely. This is our protocol. I know that there are people who recommend like you do. I have nothing against it, but we don't.
And sir, already you mentioned about the pre-operative counseling and documentation regarding the sexual dysfunction and infertility risk counseling in the reproductive age group patient. And in reproductive age group patient, sperm banking and ovum cryopreservation is also needed.
When will you do the ovum cryopreservation?
Sir, in female patient, if there is high chances of the infertility, and
my question,
in some studies, sir,
when will you do it? That was my question. In a female patient says, I want my ovum preserved in case I become infertile. I would like to have my ovum for in vitro fertilization. When will you take the ovum?
Sir, no idea about.
You have to take it before you start the neoadjuvant radiotherapy.
Okay, sir.
So this discussion cannot be had when the patient has come to you with neoadjuvant chemoradiotherapy. Already the ovaries have been badly hit, and some genetic abnormalities might have already occurred in the eggs. We don't know. So you don't want to do this before. So you have to do it before starting neoadjuvant chemoradiotherapy if the ovum has to be functional and if the sperm has to be stored. This has to be banked before starting any therapy, including neoadjuvant, because radiation will affect the ovaries because you can't avoid it, and radiation will affect the testes and the sperms. You can't shield them at all. There are some shields available, but I don't know how effective they are. But better is, if they're interested, you have to do it prior to starting any therapy. Okay?
Okay, sir.
You should start. Yeah. Okay, go ahead.
And in some patient, placement of the ureteric stent is mandatory if the imaging pictures are showing the hydroureteronephrosis. Then the ureteric stent is useful for the better identification of the ureters intraoperatively.
If the patient has hydronephrosis on one side pre-operatively, what does that mean?
Sir, the tumor is indenting or compressing the ureter in the pelvic course of the ureters.
So, how does the ureteric stent help you?
So during the lateral dissection, we can palpate or we can prevent the injury to the ureter because of the stent is already placed.
Okay. Do you want to prevent the injury? I would argue that if the ureter seems infiltrated or it's too close to the tumor, you should have asked your urologist for it to be available so that you can resect the ureter with the tumor. Because if you try to separate it, then that separation may be in a plane where there is some tumor cells, if there is infiltration. So I would say that you should actually en bloc resect the ureter if you feel that it's involved, and if it's very close. And the ureteric catheter actually stiffens the ureter. And so I would look at the fact that if there's been a previous pelvic surgery, if there's been something to suggest that there's going to be a lot of adhesions or it's a large tumor despite neoadjuvant chemotherapy, then you put the stents to prevent an injury, because the ureter you want to identify and separate it, not because it is already got hydronephrosis. If it has got hydronephrosis, it's already pressed or infiltrated, in which case it has to be resected and probably a reimplantation into the bladder has to be done with a Boari flap, for which you require a urologist. So it's safer to do that. The stent may not help if there's already a pre-existing hydronephrosis, because then if you will be separating a ureter which is already infiltrated. So be very careful.
Yes.
Go ahead. Next slide.
Sir, I would go ahead with the operative steps. I will describe the abdominal part and perineal part separately. The position we use is the Lloyd-Davis position, and patient.
Yeah.
Patient is secured to the table to prevent the injury due to patient slippage. And ideal position is the head down and left up position, and we usually keep the bolster below the pelvic rim.
And I haven't seen you on your diagram. The patient is not tied down. He will fall if you laterally tilt him.
Sir, so the proper secure to the table is required, sir.
So where is that where do you do that?
Sir, at the leg also, and at the chest level also, sir.
The leg, what will happen is he will fall down with his leg hanging fixed, and he will be down, dislocating both his hips. So you have to fix the body with a nice strong belt across the arms and shoulders so that he will not slip off the table. And there are anti-slip mattresses available for specific purposes, so you can use one of them if you're doing a lot of cases. Yeah.
Yes, sir. In our institute, sir, we use the hand.
Go back to your previous slide. Yeah. Now, in this position, do you think you can really reach the rectum?
No, sir. Head down and left up position is required.
Even if you are there, tell me, will you be able to do the perineal part in this position?
No, sir. Perineal we in our setup, sir, we convert after the abdominal part is over, we convert the position to the high lithotomy position, sir.
So after the abdominal part, you'll put a high lithotomy for the perineum. Okay, I agree.
Sir, this two diagram is first one is for total laparoscopic abdominal perineal resection, and the second one is for hand-assisted laparoscopic abdominal perineal resection. I would like to describe the method and port position according to hand-assisted laparoscopic abdominal perineal resection. The incision is given at the umbilicus, 4 centimeter vertical incision is given, and 3 ports we commonly use. 12 mm port in the right iliac fossa for the 12 mm endo-GI stapler, and 10 mm in the right lumbar region for the camera port, and optional port in the left lumbar region can be used for the bladder retraction. It is a 5 mm port.
What I can see, you put a 10 mm port.
Sorry, sir.
What I can see in the left side, you put a 10 mm port. Isn't it? It doesn't look
yes.
like it's a 10 mm port. Okay, go on.
And so dissection begins with the staging laparoscopy. We have to rule out the peritoneal metastasis and the liver space occupying lesions. And after the negative staging laparoscopy, packing of the small bowel in the right upper abdomen is required.
In the position in which you put the camera and the patient position, you will hardly be able to see the liver. For seeing the liver, you require a head up, and the camera will have to be a little higher up. Otherwise, from where you put, it will be very difficult to see.
Yes.
So in the age of modern imaging with high quality CT scans and everything, really, very rarely you'll find a secondary in the liver which has been missed on a CT scan. So I don't know whether if you can see, yes, but you may not be able to see the whole of this, especially the superior part of the right lobe, you will not be able to see in this position. With the camera where you put it, you can't see.
And so after the staging laparoscopy, with the assistance of the hand inserted through the hand port, the sigmoid is pulled out from the pelvis, and traction is given on the sigmoid mesentery through the hand, and inferior the vascular pedicle and the sacral promontory is identified, and first incision is given at the retroperitoneum, and automatically the CO2 inflates into the loose areolar tissue, and dissection is continued with the creation of the tunnel behind the sigmoid mesocolon, and dissection is continued to the medial to the lateral fascian, and during this dissection we have to prevent injury to the iliac vessels, ureter and the gonadal vein.
How do you identify the ureters?
So the ureter is identified with its characteristic peristaltic movement.
But where?
At the bifurcation of the abdominal aorta into internal iliac and the external iliac vessels.
So it crosses the common iliac just before the bifurcation, isn't it?
Yes, sir.
Have you heard of any anatomical abnormalities where you will not be able to see the ureters?
Sir, in left pelvic ectopic kidney, kidney is lying in the left.
Kidney is in normal position. So, so on the right side you can have a retrocaval ureter. So then you won't see it in its normal position. Okay? And on
Okay.
the left, you can have a retrocommon iliac ureter, the equivalent of the right-sided retrocaval ureter, and which will not be seen sometimes. So the ureter will not be seen sometimes crossing the ureter, crossing the iliac, because it's going behind the iliac. I've had one case where I was in a workshop and this exactly happened. I was sure I had not divided, but everybody in the audience saying you have divided the ureter. Then finally I went up, traced the ureter and showed them it's going retroiliac. 3 urologists came from the audience to see the thing because they have never seen it. And when they saw it and they said everything, they were amazed that I could dissect it like that and show it to them. And they were really happy to see such a rare anomaly. But remember that it can happen. Okay, then what will you do?
So after completion of this tunnel, we usually put the ghost piece in this tunnel, and the lateral mobilization begins with the division of the parietal attachment of the sigmoid colon, and after dividing the line of the toll, the previously placed ghost piece is identified lying in the retroperitoneal tunnel, and this completes the dissection. And after that, we usually divide the vascular pedicle.
Gauze piece, and where do you find the gauze piece?
Sir, in this image, this is the tunnel we made behind the
You put a gauze piece there. And
yes.
where are you going to identify the gauze piece when you come from where?
Sir, after completion of this tunnel, we begin the dissection for the division of the linea of the toll. And after this completion, complete dissection and complete division, the same ghost piece we can see from the laterally.
Okay, I don't think it's a very important thing. We don't have to see the gauze piece. You know what you're dividing there. Okay, as long as you have the ureters away. Yeah.
Yeah. And ligation of the vascular pedicle we perform after the lateral mobilization of the sigmoid. The IMA ligation can be divided as a low ligation and the high ligation. Low ligation is the ligation of the inferior mesenteric artery just distal to the origin of the left colic artery. And IMA ligation, high ligation is its ligation is at the point of the origin at the aorta. In our institute, we prefer the high ligation when there is high probability of the lymph nodes and greater enlargement of the lymph nodes at the IMA origin. And ligation.
You expect the tumor for which you're doing an abdominoperineal resection to really have that high a lymph node. So I think this high ligation for an abdominoperineal is really not very important, because the tumor is so low that it doesn't come to this level of lymph node thing. If you're doing an anterior resection, especially for a growth in the rectosigmoid, there yes, because the growth is very close to the IMA, you expect lymph node at the base, and you can divide it there. And I don't think that, especially for a abdominoperineal, if you want to leave more of the sigmoid, then it is better if you divide the IMA distal to the LCA, because then the sigmoid will have a better vascularization, especially in elderly patients, patients with COPD, patients with diabetes mellitus, CKD, where the vasculature is likely to be diseased. You want an extra artery in the form of the IMA, so of the LCA. So I would divide the IMA below the LCA in an abdominoperineal resection and preserve, especially in patients with comorbidity. Younger patients, I would go higher. The problem with going higher is that you tend to injure the nerves from at the hypogastric plexus more, because the nerves come near the base of the IMA. You actually do a nerve drop to dissect the nerves away from the thing. But even that can damage, so better to just stay a little away, because it really oncologically it makes no difference.
Yes. And sir, I would like to show the one video of the above dissection.
We will skip the video because we have a short of time. Let us go to
the... And the after complete mobilization of the sigmoid, the other other part is the mobilization of the rectum. Mobilization of the rectum, we have to understand the TME plane. TME plane is the avascular Holly plane
I thought
between
you done the TME. I thought you have put the gauze piece after doing all this, no? So you put the gauze piece without doing the TME?
Yeah, ghost piece is ghost piece is put during the dissection of the sigmoid mesocolon, sir. It's a retroperitoneal tunnel, sir. First, we put the ghost piece behind the retroperitoneum, sir, at the dissection during the sigmoid mesocolon, sir, not during the TME plane.
Why do you want to do so much dissection of the sigmoid mesocolon? I have not understood. What is your, you are going to do an abdominoperineal dissection, okay? So you don't want to remove too much of the sigmoid colon because that is the one that is going to come out. If you remove that, then you'll have to do descending colon mobilization to bring out the end. So you don't require to remove so much bowel in abdominoperineal. Why do you want to remove all the sigmoid colon, mobilize it all free? Sigmoid colon can be left after you divided the LC, you just go into the retrorectal plane. Why do you want to mobilize so much of sigmoid colon? What is the use of mobilizing so much of sigmoid colon? Sigmoid colon is usually free. You don't have to do a retrosigmoid dissection at all. You just divide the structure, it just comes hand free and that will come up into the abdominal wall easily as a thing. I thought you'd put the gauze piece after doing the TME dissection. So I don't know why you did so much of dissection in this area, which is actually part of the TME dissection from what I can see. You're going down into the, see, once you go below the pelvic brim, you're doing TME dissection. Isn't it?
Yes.
Where does the sigmoid become the rectum anatomically?
Sir, at the sacral promontory, sir, and anatomically where the tinea of the sigmoid.
Please tell me the anatomical definition where the sigmoid becomes the rectum.
Sir, where the tinea of the sigmoid colon coalesces to.
But what does the books in anatomy say that this is rectum, this is sigmoid? They define a certain landmark. Since you seem to know not to know that.
Sir, at the sacral promontory line.
It is not at the sacral promontory. It's opposite the third piece of sacrum. Please go look up your anatomy books. The sigmoid becomes a rectum according to the anatomy books opposite the third piece of sacrum. This is given in all the anatomy books. If you read it, you will know.
Yes, sir.
So the problem is that you people don't read anatomy. You just go and read some operative textbook. You have to read anatomy first and understand the anatomy and then do the surgery. So the surgeon, that's why they don't say rectus. They say this vague area rectosigmoid, which includes the upper rectum and the lower sigmoid, which is opposite the promontory and goes up to the third piece of sacrum. All that they defined as rectosigmoid. But frankly, a rectosigmoid growth would be one that will not require more than an upper section of the rectum. So in which case you should not need to go do a TME. So it's not of any use in a APR. Okay, so you do a TME. We have already discussed the problems of doing the TME. Then what do you do?
And so the sharp dissection is continued between the avascular plane, between the fascia propria and the presacral fascia, and we have to incise the rectosacral fascia at the level of the S3 and S4, and sweeping.
You have posterior. What is the fascia called?
Posteriorly, fascia is the presacral fascia. It's anatomically we can say the visceral and parietal layer of the endopelvic fascia.
What is the name of the fascia? It's called the Waldeus fascia.
Waldeus fascia. Yes.
Yeah. So it has two layers: a visceral layer and a parietal layer. So using posterior, this is the two layers: a visceral layer and a parietal layer. The nerves lie posterior to the parietal layer, isn't it?
Yes, sir.
Yes. So if you go in the correct plane in the Waldeus fascia, which is between the visceral layer and the parietal layer, the nerves will automatically be preserved because the fascia lies on top of it. So that is why you look for the plane there. That is the TME plane of Hill.
Yes.
The holy plane of rectal dissection, as he called it in his original articles, the holy plane of rectal dissection. Yeah.
And during this dissection, sir, the ideal technique is the sweeping movement toward the rectum, and all fat belongs to the rectum. We should always remember these things during this dissection, sir. And anterior dissection begins with the peritoneal incision 5 mm above the rectum, and dissection continues anterior to the denovelar fascia, and neurovascular bundle lies at the 10 and 2 o'clock position.
The neurovascular bundle comes in between the two layers of the denovelar fascia. They don't just see. You will see here that the nerve to the lateral bundle has gone, but the nervi aerogentis will go separately from their lower down. So if you stay close to the rectum, you won't damage the nervi aerogentis. The nervi aerogentis are these two nerves which will cross anteriorly between the two layers of the denovelar fascia. But in an anterior tumor, you can't really save. In a posterior tumor, you can go behind the Waldeyer fascia onto the fascia propria of the rectum, because there, the posterior tumor, you don't need an anterior clearance of that extent, so you can preserve the nerves completely.
And so pelvic mobilization of the rectum continues with the lateral dissection. That the thin space between the pelvic plexus and the fascia and connective tissue with autonomic nerves is present, and there is also the inconsistent arterial branches. We have to carefully divide this to prevent the torrential bleeding during the lateral dissection. And lateral dissection
is a mild bleeding, you can always control it. It's not torrential.
Yes.
See, unless the torrential bleeding comes when you damage the venous plexus.
The presacral venous plexus.
It doesn't come when you damage the arterial plexus. The arterial plexus will bleed, but then you can always just put a pressure, it will stop. The venous plexus won't stop easily, and it will have to be controlled. So you have to identify the veins and stay away from them, especially the internal iliac vein, the branches of the internal iliac vein. If you see, then you may need to put a clip, or you may need to use a vessel sealer to make sure that you don't damage the branches of the internal iliac vein, because they will bleed very badly.
And during lateral dissection, we have to protect the autonomic nerve plexus, iliac vessels, and the ureters. Video I would like to describe, but due to time shortage, I'm skipping this video.
Now, what have you used on your perineal dissection?
Sir, the second part is there, sir. Perineal dissection begins with the position. Some institute prefer to do the perineal dissection in the prawn jackknife position, but we prefer the perineal dissection in the high lithotomy position. So we usually change the position during the perineal part of the abdominal perineal dissection.
Which abdominal perineals will require a position, a prone position?
Sir, during the anterior,
my question is very specific. Which are the abdominal perineals where you cannot do it in the lithotomy position?
Sir, in extra elevator approach.
So, if you are going to do an extra elevator, if you plan pre-operatively that you want to do an extra elevator operation, you cannot do it in the supine position, in the lithotomy position. You have to do it in the prone position. First, because you have to do a wider resection, you have to go extra elevator, and secondly, to reconstruct the defect, you have to call a plastic surgeon who will usually do a bilateral gluteus maximus flap, rotate it round and close the gap. So for an extra elevator, you have to go for the jackknife, and the position as you show it is not the correct position, because this position you can't operate. Where will you stand and operate? So the jackknife position, the legs have to be spread apart, just like you do in a lithotomy, and you have to stand between the legs and do the posterior dissection. So with your legs straight like this, you cannot do a posterior dissection. The legs have to be kept spread apart. Straight itself, you can keep it straight and spread apart. Then only you'll be able to get between the legs and do the, in this you have to stand on one side, and you can't do a proper perineal dissection standing on one side. You need to stand and watch at it from the midline. Okay?
Okay.
In my unit, all abdominal perineals are done in the prone position for the elevator dissection. The reasons are, it is much easier to do that. You don't strain and look like this. Secondly, the lighting is always poorer when you're doing it in a lithotomy position. You have to keep screaming at the light fellow. Sometimes the light can't come low enough to show. Then you have to hold a torch. In this position, the lighting is no problem. It's on the back. It's straight down. The lighting is very good. Secondly, the important bleeding that occurs in the perineal dissection always comes from the prostatic bed if your tumor is infiltrating or you've gone in the wrong vein. And then you have to control the prostatic bed. So in the lithotomy position, the prostate bed is anterior, higher. So you have to bend your neck and then do the hemostasis with poor light, or you have to use a headlight, and then when you use a headlight, nobody else can see except you. And then you have to do the hemostasis. Whereas in this, the anterior lies straight below you. The light is on it. So easy to do the hemostasis. So we have shifted completely to all abdominoperineal dissection being done in the lithotomy position in our unit. And since we shifted about 8 years ago or 9 years ago, we have found it to be so easy. It's just the time is there for half an hour to shift the patient on. The procedure becomes so easy and so good that it is not worth trying to do it anymore in the lithotomy position. If you are starting an abdominoperineal resection for the first case in your career, what is the case that you would like to do? The first case you're doing an abdominoperineal resection. What is the case that you would like to do? So the case that you would like to do, which I will give it to my postgraduate as the first case of his career in an abdominoperineal resection, is a woman with maybe a low with an anal canal cancer which is recurrent or something, where the rectal mobilization will be essentially a normal rectum and the perineal part can be done easily under vision. So when you're doing a perineal mobilization in an APR in a woman, what do you do for the so this position of putting the patient in jackknife is wrong for an APR. Sorry, this is absolutely wrong. You cannot do an APR in this position, so you can forget that. Okay?
Yes.
You can forget that. Okay. This is so you put the this is in a lithotomy position or in a prone?
Sir, in a prone jackknife position.
Prone jackknife. So obviously now you got the legs apart because you're in between.
Yeah.
Yeah, so you now put the legs apart. So your legs are apart. Obviously, you can look at it. So that way is the way to do it. Okay.
Yeah, and so perineal dissection begins with the pulsating suture of the suture at the anus to prevent the contamination of the pelvic wound. And teardrop incision is given to with the margin of 2 centimeters from the anal verge. And division of the anococcygeal raphe and reaching the coccyx is required. And levator muscles are identified and dissected during the pelvic dissection. And during this levator ani dissection, ligation of the inferior hemorrhoidal and the pudendal vessels is required to prevent the bleeding, and progressively elevating the rectum of the presacral fascia is required. And transverse incision is given to expose the transverse perineal muscles, and division of the pubococcygeus and the pubourethralis muscles.
Transverse incision, I don't see a transverse incision. Only seems to be an elliptical incision.
Sir, a transverse incision is given at the muscles, at the position of the transverse perineal muscles.
I put a transverse incision at the level of the skin. About
no, at the level, during the, after division of...
What I do, I put a transverse incision at the level of the skin, about a centimeter or 2 below the coccyx, okay?
Okay, sir.
Then I bring it round the rectum till I reach anteriorly, and then I don't put a purse string, I divide the two ends and then I hold with 3 Allis both sides. Then I can hold both sides of the divided skin and subcutaneous tissue. And that closes the rectum. So there's no, and since the bowel is prepared, there's no contamination. In the olden days, they didn't prepare. There used to be contamination. Now we prepare, there's no contamination. And then I divide the muscles. My first goal is to go posteriorly and divide the sacrococcygeal raphe. And once you divide that, you will be into the pelvis. you'll actually feel the mobilized rectum that you mobilize. And then you can just enlarge that opening, and then you can put your hand in and bring that rectum out. When you bring the rectum out, then the rest of the dissection is very easy because the rectum is out, and you can actually put your hand on both sides to protect the levator, and I divide it with a diathermy on this side, diathermy on that side, do the hemostasis. And then you'll come last to the anterior, where you have to be very careful. What is the structure that you have to be careful of anterior?
So anteriorly, we have to protect the seminal vesicles and the prostatic plexus.
Seminal vesicles are much higher. You have protected them when you're doing the abdominal dissection. It doesn't come during the perineal dissection. Sorry, your anatomical concepts don't seem to be very clear. The seminal vesicles don't come during the perineal dissection. They come during the abdominal dissection. They are behind the prostate, higher up. And that's where they will come together, and you will see them there. And you would have protected them there. You don't have to protect them from the perineum. I have never seen them from the perineum. What else will you do?
So this figure shows the division of the anacoccygeal raphe and division of the levator ani during the perineal part of the dissections. And the pelvic after the
it is showing something else. What else is it showing? What else is it showing?
This figure shows the division of the anacoccygeal raphe.
This patient, you said, is in the prone position.
Sir, this photo is of lithotomy position, sir. The previous photo was.
Why one photo you're using prone, one photo you're using lithotomy? See, yes, now I understand in a lithotomy that will be anechoic, but then I was thinking that your previous photo you showed was prone. Therefore, if it is prone, then this can't be anechoic. This has to be the anterior dissection. Okay, so this is what we divide that early and pull the rectum out so that it everts out. And then when it everts out, it's much easier to just remove the specimen. If you try the next time and evert the rectum out, you will find that it becomes so easy to do the division. And you can see that this gentleman is also using only the Alice to hold the rectum close now.
Yes, sir. And after the specimen removal, we usually give the saline, betadine and saline wash with the hydrogen peroxide, and we pack the cavity for a few minutes for better achievement of the hemostasis. And all the bleeders is individually tied and cauterized, and better hemostasis is achieved. And pelvic floor muscle is closed.
Patient, when you're doing the perineal dissection, what do you do with the vagina? What is your doing with the vagina? Do you go between the plane between the vagina and the rectum? Or do you remove part of the vagina? What is your usual practice?
Sir, we usually protect the posterior wall of the vagina. If the tumor is infiltrating, then it is required, the removal of the posterior vaginal wall is required.
I never try to, especially in a woman, especially with that multiple deliveries, the vaginal rectum wall is very thin. And you try to do division between the vagina and the rectum, you'll do buttonholes in either the vagina or the rectum, or you'll devascularize the vagina. So I don't hesitate. All my patients of female, I do excision of the posterior half or even 2/3 of the vagina, along with the specimen. So once I've got it out, then it's very easy to do that. And that by leaving the anterior 1/3 or so of the vagina, I protect the urethra in the female. The urethra is protected. But I remove the vagina posterior, and I don't try to recreate the vagina. I just close it and leave it as a hole, and it just nicely epithelializes, and in no time a new vagina forms by itself. There is no need for you to do any reconstruction. It forms by itself. And I always remove the posterior half of the vagina. Most people do that also. So if you keep trying to dissect between the vagina and the rectum, you'll get into trouble. Many of these growths are circumferential, and then anyway you have to remove the vagina. So routine removal of vagina is sometimes advocated by many oncologists and GI surgeons. I also advocate it usually. Yes, next. What are the complications in the post-operative period?
Sir, complications I divided is the abdominal complication, perineal dissection, perineal complications, and the other general complications. Abdominal complication, most common ones are the post-operative ileus and the early small bowel obstruction due to early adhesions in the pelvic cavity. And perineal complications are wound.
So, do you know of any maneuvers where you can prevent these adhesions or try to lessen these adhesions?
Sir, in some institute, the omental packing in the pelvic cavity is useful to prevent the adhesions in the pelvic cavity. So the omentum is divided from the transverse colon and it is mobilized and packed in the pelvic cavities.
That's one way, but then the bowel will get stuck to the omentum.
And other is the to close the pelvic peritoneum in the vertical or the transverse manner with the absorbable sutures.
If you have done a proper APR, you will have gone so wide that you can't close the pelvic peritoneum unless you use a mesh. If you use a mesh, invariably adhesions of the bowel to the mesh will occur. So somehow I don't think you can close the peritoneum. That means that you have sacrificed so less of the peritoneum that it is not really an oncologically correct operation. After I do an APR, it will be almost impossible to close the. So we do a simple thing that for 48 hours after the operation, after an APR, we keep the foot end of the patient up for 48 hours. So that the bowel falls away. Whether it does, I don't know, but the small bowel falls away from the pelvis, and we hope that it will prevent adhesions. After in the surgery, you do that and the bowel falls away. So we assume the same thing that will happen in the post-op period. We keep them leg up for 48 hours, leg end of the bed up, and so the foot end of the bed is lifted onto. We have made 1.5 foot high wooden blocks on which it is raised so that the bowel will remain below. Similarly, for an anterior resection where we want the bowel to fall into the pelvis so that there is no strain, we put the blocks under the head end for 48 hours so that the rectum falls into the pelvis and there is no tension on it for the first 48 hours. I don't know whether it works, it's just something that we do. We've been practicing for a long time and we feel that it may help. I have no scientific proof that it helps, but it's something that you can think of that you do. Let us say that after 48 hours, your resident calls you and says, I don't like the color of the stomach. And you go there and you see that the tip of the stomach seems to be a little dark. What are you going to do now?
Sir, I will wait for another 12 hours because sometimes the stoma is dusky and the vascular supply from the marginal artery of the Drummond
48 hours, you'll wait for 60 hours. At 60 hours, the color is exactly the same what it was. It is slightly dark, not definitely gangrenous. You don't know what to do. What will you do?
Sir, I would prefer the stoma revision.
Revision. So that is one thing. The second thing you can, anything else you can do? You're a GI surgeon, not an oncologist, so this should strike you. So what I would do is that I would do a stomoscopy. Put a cornoscope into the stoma and look at the color just beyond the edge. If it's nice and pink, then just the edge that is black, I would wait. I can always revise it at a later date. If it blackens out, but it may become all right. I see. My problem is I want to know whether the blackness is going down into the stoma that's in the wall or in the abdomen. If it is, then I will do what you said. I will revise the stoma. But if it is not, then I will probably wait. If it's just the last 1 centimeter, which is a little dusky, and the rest is all right, pink, I would wait. This is something that you can always do on the bedside. So you have done an esophageal anastomosis. Suddenly the patient is not doing well. Your first concern is that whether this loop is ischemic. And you do a creatinine, it is now 2.8, so you are not able to think of doing a contrast in on CT, patient on a ventilator or on a this thing. So you don't know what to do. One of the things you can do is you can put a scope through the mouth into the jejunum very carefully and expert endoscopy should do it, and you look at the color of the jejunum. The color of the jejunum is nice and pink, then you know that this is not the problem, something else is the problem. So you automatically rule out ischemia of the jejunal loop once you pass the anastomosis and it is nice and pink. So scopy on the post-operative period can be very useful in you have an ileostomy looking dusky, you want to see whether the lower one is dusky, you just put a scope, the rest is pink, you can wait for some time. So these are things that we can do on the bedside. The patient, you remove the catheter after 5 days. Normally 4 to 5 days we remove the catheter. He doesn't void urine. What will you do now?
Sir, it can be related to the intraoperative injury to the parasympathetic plexus of the urinary bladder. So we have to do the uroflowmetry and document the bladder dysfunction, sir.
So will you do it on the 4th and 5th day?
Sir, literature shows that sometimes the this urinary difficulty or the problem of the hesitancy improves.
You are in the ward. You are removed the catheter in the morning. Nurse has called you at 5 o'clock and said patient has not voided urine. You palpate his abdomen, his bladder is almost halfway up to the umbilical, so he's got a lot of urine inside. What are you going to do? You want to do a uroflowmetry?
No, sir.
During a uroflowmetry, he has to pass urine, no? How will you do
recatheterization
and what? See, thing is that you are not an MS postgraduate, you are an MCH postgraduate. You are going to do these operations, you are going to manage them, and some of them will have these complications. So you should know what is to be done in these situations. The normal routine that most people will follow is they will recatheterize them and wait for 3 weeks. Send them home with a catheter and tell them that after 3 weeks we'll admit you and we will remove the catheter, give a trial removal of catheter, and 17 to 80% of patients will void the second time. Okay? And if they don't void, then you call your urologist colleague to find out what is wrong. And then he will not do a uroflowmetry, he will do a cystometrogram to see what are the pressures in, whether there is some, whether the patient, he will also clamp the bladder catheter for some time maybe and wait and see whether the patient feels the sensation of urine. Now, if the patient doesn't feel the sensation of urine when the bladder is halfway to the umbilicus, that means that there has been neural damage. In which case, you have to start implementing some strategy, which may be some drugs which the urologist may suggest because he's a male patient, prostate may be enlarged. You may start Rapilef and just wait for some time. Or you have to tell the patient that you may have a bladder injury. We can keep the Foley's for maximum another 1 month and then try again. If you void, okay. At the end of 2 months, if they don't void, that means that they have got a nerve injury, which is not going to become very easy. And it's not very easy to treat a nerve injury. Then you have to discuss with the patient. The best options would be a self-intermittent catheterization. Because it has been shown that you can do a self-intermittent catheterization every 4 to 6 hours. The patient himself will do it and empty the bladder. And they do reasonably well. Many years they live, and the chance of infection, as long as you don't leave residual urine in the bladder, the chance of infection is very low. So self-intermittent catheterization. So you should know all these things. So you should know the options of problems after surgery. One is urinary, second is sexual. Sexual, well, you wait for some time, sometimes it will return back to normal. It doesn't, then you send him to an andrologist, somebody who's, every urologist is not an andrologist, please remember that. Yes. Most urologists don't know much of andrology, so you have to spend to those people who know something about andrology. And they will tell you that what drugs to use, what methods to use. They can teach him some other techniques, vacuum pump, things like that, or put a prosthesis if they want. So there are many options which he can discuss with a good andrologist, which the average urologist may not be.
Okay, sir.
So these are all things you should know. So we'll stop with you and we'll go to the next candidate because we have run up to 8:50. We have got another maybe 20.
Sir, we have to conclude now. We will do this session in the next.
Okay, we can do the next session. Then we can spend some more time on abdominopenial resection, perhaps.
Okay, sir.
10 minutes more we can spend. If there are any questions from the audience, I will take it. I'll just come.
trainees, if you have any questions, you can just quickly type in the chat box. Asking questions will help you to clarify your thoughts and those of others too. Thank you.
Yeah. Okay. Any questions we have? You can put it in your question box. We can discuss problems. So let us say that this patient you operated comes to you after 4 years. His colostomy is not working so well. He has got some constipation. And when you look at it, the whole colostomy seems to be bulging from the abdomen. What do you suspect?
Sir, parastromal hernia.
We'll ask the other candidate to answer also. He can also take part.
Yes, sir. After 4 years, it could be a parastromal hernia, as he said, sir.
Okay. So how will you diagnose whether he's got a parastromal hernia?
By firstly clinical examination, sir.
Clinical examination. Okay, all you see is a bulge. What will you do? What investigation is of choice to rule out or rule in a colostomy hernia? Paracolostomy or a para-ileostomy hernia?
CT scans, sir, of the abdomen.
So you will do a CT scan abdomen. That's the investigation of choice. Okay,
Yes.
so that will tell you whether there's a hernia. Let us say that there is a hernia. Now, what can you do? Now, the patient is obviously bothered by the hernia, is having constipation. What will you do for the patient? You got a paracolostomy hernia approved on CT scan. What
Yes,
are
sir.
your options and what will you tell the patient that I can do?
We'll have to plan for a re-stoma, sir. If the patient is being bothered by it.
So, what do you mean by a re-stoma?
Like a revision of the stoma, sir. We'll have
No, a re-stoma is different from a revision of the stoma.
revision. I meant revision of the stoma, sir.
Not a revision of the stoma. How will you revise it? So, you have to now make sure that there is no hernia. So, how are you going to prevent the hernia? That's what I'm asking you. Do you know of any operations which are described for treating the parastromal hernia? So, since you don't seem to be very clear, I will give you the guideline. The guidelines are as follows. One is that you recite the hernia. Okay, so you take it down from the left iliac fossa and bring it down onto the right iliac. Okay, a new stoma. And on the left iliac fossa, you can close the hernia with a mesh. Okay, now you don't have a stoma there, you can close it with a mesh. Then you hope that at the new site the hernia doesn't form. The second option is to release all those bowel adhesions on inside the stoma, bring it down, and then use a mesh to cover the gap. Now there are 2 or 3 ways of using the mesh. One is you take a flat piece of mesh into which, like the State Bank symbol, you cut vertically and then make a round for the stoma. So which you place inside the abdomen and then you place it around the stoma. The stoma comes through the gap and then the 2 flaps are tacked on to each other below the stoma, and the rest of the mesh is tacked to the abdominal wall around the stoma. So your stoma acts as an IPOM inside, but with a gap for the mesh to come out. And to help you place the mesh, you also make a slit in the mesh so that it can place it and then cover it, but it must come out through that gap which you've created. This is fairly successful. The other operation is to do the Cleveland Clinic type of operation, where you use a big mesh and put it right across the bowel onto the lateral abdominal wall from the stoma to the lat. So the entire mesh is covering the entire stoma, the gap. So the bowel goes under the mesh and then comes out as a stoma, and it is covered on all sides. So the only problem with that is that sometimes if you are put it too tight around the bowel at the lower corner where it's entering the mesh, you may cause constipation. But it's considered to have a superior result to the previous operation I described to you about the slit and the putting it. So this is the second operation that you can do. The third operation is an open operation. You can go and remove all the adhesions, close the site with some primary sutures, and then put a mesh around it under an open operation instead of doing it laparoscopically, and fix it and make sure that it doesn't occur. The success rates of these operations are reasonably quite good. We don't have too much of an experience with colostomy site hernias. We have maybe done in the past, see, because I think many patients don't come back to us, or they don't survive long enough after the operation due to the recurrence of tumor or liver secondary or something. They don't come back to us. So we have had about 5-6 patients in the last 10 years who come back to us since we identified these problems. And in 2 patients, we resited the hernia and closed the hernia primarily. They are both doing well. They have not developed new hernias at the site. In the other patients, we have done the Cleveland Clinic procedure. We have done one patient where we did the SBI technique of the putting the circle and the cut, but that patient didn't do well. We had to reoperate him and resite his hernia and then use this mesh to close the site. And on the other, the ones with the Cleveland Clinic, they have done well. They are actually doing well. They don't have any recurrent hernias. They are doing reasonably well. So
but constipation is there, sir, in that Cleveland Clinic patient?
If you put the thing tight around the core, it can have constipation. But if you don't put it very tight there, there's always a chance of a small bowel loop going in, but by and large it doesn't. It doesn't become very tight, means it will be okay. The ones we have done, they have not had any constipation, any problems with the course of obstruction. But I'll have to read literature to tell you exact incidence of whether constipation is there or not. Like, nobody has big series of these. Now, this is where we have changed again in the last 5 to 7 years. I put a mesh routinely at the time of creating a stoma for the APR. So whenever I create a stoma for the APR, I always bring it transrectal. I don't bring it by the side of the rectus muscle. I bring it from inside the rectus muscle. And then I bring it out. I put a mesh, which is about 3 by 3 inches, about 7 by 8 centimeters by 8 centimeters, around it with a hole in the middle for the stoma to come through. I fix the mesh to the stoma. I fix the mesh to the sheath, and then I mature the colostomy. Now, there are studies which show that putting the prophylactic mesh doesn't help. These are some of the randomized trials from Europe which shows that it doesn't help. But I have put it that there has been no post-operative problems with putting the mesh. There has been no rejection of infection of the mesh, or we have to take it out. The patients have been okay. It is too early to say whether they're developing hernias because it's only been for the last 5 years that we're doing. But in the follow-up, most of the patients don't seem to have a hernia at the moment. They have not come back with a hernia. So since the number of APRs we do now has considerably come down, the complications also are seen in less patients. So it becomes an anecdotal experience rather than a large experience.
But in the last 5 years, you've been using prophylactic mesh for all the APRs, sir?
Yeah, I use now for the last 5 years, all the APRs, yes.
Okay.
So I don't know whether I am justified, because originally they said it is good, but then they came up with some randomized trials which said the hernia formation is the same. Now I don't know what is the logic of my doing it in spite of this, but then I've been doing it for 5 years. I've had no problems. I haven't had patients coming and saying I've got some problem which we have diagnosed as a hernia. So, but then some patients don't come back to me. They may have gone out elsewhere for a hernia repair. I don't know about that. So, since it is not very difficult to put the mesh at the time, and we don't buy a mesh. We have a lot of meshes. We use big meshes for incision hernia. So we have a lot of pieces lying around. We take one of those pieces and patch it on, and the patients don't have problems with it. So far, no mesh erosions and other things. But yesterday I had to remove the first mesh so prior to 2005, I used to put mesh for all rectal prolapse repairs. After 2005, I stopped putting, but this is one of the patients I did before that in 2003 or something. 20 years later, now he came with some rectal problem and we found the mesh is almost wholly lying inside the abdomen, inside the rectum. So we tried to remove it. It was very difficult to remove, but we have removed most of it. We'll see how he does over the next few days. Because it's an extraperitoneal mesh, we hope that he won't have a fecal leak or a post-op complication. So there's a part of the mesh is still left behind, which is we hope to remove at a subsequent sitting, maybe 2-3 years hence when it has eroded a little more and come out. So whatever is eroded out, we have removed, but there's a little mesh which we can feel behind, which we have not attempted to remove. Whether titanium mesh can be used intraperitoneal, they say that it is as good as that. But it's basically from an Indian company. So I don't know what is the quality of evidence that they have regarding these titanium meshes that they don't get adherent. I have not used it intraperitoneally yet. I still use the Paritex or the Ethicon dual meshes, biolayer, double meshes for this. But I can tell you that even with these, when we have gone in for some other surgery or when we have gone in to do a reoperation, we find that yes, bowel doesn't get adherent, but there are a lot of omental additions to these meshes. So it is not that they are completely adhesion free. What we have seen is that they don't have bowel adhesion, but they do have a lot of omental addition. So you can't say that no, any of these meshes have no additions. They all have some additions or the other. And especially they have additions to the corner, where there is a area of, I think, transition between the mesh to the abdominal wall, and that area, they tend to get adherent. I don't know why, but there is some, maybe the edge of the mesh is easily adherent rather than the surface. So be careful. All these meshes are not 100% safe, but at least with the double meshes, we have not seen fecal fistulas coming out, which we have seen with Prolene meshes put inside the abdomen. In the olden days, people used to put Prolene mesh inside the abdomen, and I've done a few, maybe 3 or 4 cases where the patient after 5-7 years has come with a fecal fistula. And then we go in and we remove the mesh, the bowel is adherent, and we resect the bowel anastomosis, they settle down. But this does happen with the Prolene mesh. Any other questions? Otherwise, we can call it a day and we can join again.
Sir, there is one in the chat box.
What are the questions?
Dr. Rahul.
He just says thank you. That's all. Yeah.
Okay, sir. So if no more questions, thank you very much, trainees and faculty members, for joining the session.
Thank you very much, sir.